Uh, okay. They are unrelated to this current presentation. They're mostly to do with Hep C. The content of this presentation is based on recent evidence, and I've prepared that myself without any support from any of these entities. So this is the outline of my talk. I'm going to touch on the recovery study. That is a UK study that dealing with dexamethasone, Act 1 study that's mainly focused on remdesivir. The WHO Solidarity study that had a few drugs in it, including remdesivir. And then touch on the WHO recommendations arising from the interpretation of the Solidarity study. And then just list what is in the pipeline or what's being studied or researched, and a few words on vaccine before we conclude. So to start with, this is the recovery study, a randomized study that was based in the UK, involved over 175 NHS hospitals and enrolled over 11,500 patients. It had multiple arms, Kaletra or lopinavir, ritonavir, dexamethasone, hydroxychloroquine, and erythromycin. And there was also an option for patients to receive either convalescent plasma or tocilizumab. So the study arm, the dexamethasone arm, had to be terminated early because there was already enough evidence to suggest that dexamethasone was associated with a significant survival benefit. So the study was halted in August, and it was published the preliminary report was published in July in the New England Journal of Medicine, entitled Dexamethasone in Hospitalized Patients with COVID-19, a preliminary report. Essentially, this showed a survival benefit in patients who received dexamethasone compared to the controls. But this benefit was only noted in patients who received oxygen or required intubation and ventilation. Patients who did not require oxygen did not have a survival benefit when they were given dexamethasone. In fact, usual care was better. So this is basically looking at the survival curves again for patients who received oxygen and those who were on a ventilator. And you can clearly see that the dexamethasone in the blue fared better compared to the usual care in terms of survival. And this difference was statistically significant, and that is what resulted in the early termination of the study, or that arm of the study, I should say, because the other arms are still ongoing. This is just to illustrate what I've just said in graphic terms. Anything to the left favors dexamethasone, to the right it favors standard care. And you can see that in patients who were on a ventilator or required oxygen, there was a survival benefit, but not in those who received no oxygen, because this was crossing the midline. And this is for the total overall numbers showed a survival benefit when you combine everybody together, indicating that dexamethasone resulted in a significant survival benefit, and that's why it's become standard of care, giving patients with COVID 6 milligrams a day of dexamethasone for 7 to 10 days. So next study to look at is the Act 1 study, which was sponsored by the National Institute for Allergy and Infectious Disease in the US, and is basically a multi-center randomized, double-blind randomized study looking, comparing remdesivir, which is an antiviral drug originally developed for Ebola, but it was not effective for Ebola. So they decided to study it for this, for COVID. And this was compared with the placebo arm, Remdesivir was given for a total of 10 days. The primary endpoint actually was changed after the study was started to an ordinary scale or to reduction or time to recovery. And that was one of the criticism of this study, is that they changed the endpoint after the study was started. And there are many other criticisms. I don't think we have time to go into all of them, but some other important criticism is that they didn't really so far publish what other medication those patients who received remdesivir also received. Did they receive steroids? Did they receive other medication? That is not included in the published data so far. So this study did not show any survival benefit. There was no significant difference in mortality between the active and the placebo group. What the difference was in the recovery time. The median recovery time in the remdesivir group was 11 days and the placebo group 15 days. So about 4 days shorter recovery in the remdesivir arm. That is what this study showed. But no survival benefit and no benefit in preventing progression to intubation and ventilation. So the only benefit that this study showed was a reduction in the recovery time by 4 days. Then there is the Solidarity study, which is a WHO-sponsored study. It's a very large study, 405 hospitals in 30 different countries, over 11,000 patients randomized to either remdesivir or hydroxychloroquine or lopinavir, ritonavir, which is Kaletra, or to interferon with lopinavir, or to just interferon or no study drug at all in a control arm. So this study has been published in preprint on RIV or RXIV on October 15th. And these were the preliminary data. This was the mortality data at day 28, showing no difference between the study arms and the control arm, in that there was no survival benefit in any of the patients who received remdesivir or hydroxychloroquine or lopinavir, ritonavir, or interferon. So this is the conclusion of the Solidarity, the WHO Solidarity study, is that in patients who received remdesivir, hydroxychloroquine, or lopinavir, or interferon, those regimens appear to have little or no effect on hospitalized COVID-19, as indicated by overall mortality, initiation of ventilation, and the duration of hospital stay. So there were no recorded benefits in any of those parameters. They went on to say that the mortality findings were consistent with a meta-analysis of mortality in all major trials. This is a meta-analysis that was done by the WHO, looking at remdesivir in all of the published studies, including Solidarity itself, including ACT study, and including some other studies from China. So the overall pooling of this systematic review showed essentially no difference between remdesivir and control, and you can see the two curves overlapping very tightly, showing no survival benefit and no benefit as far as initiation of ventilation or hospitalization duration. So the length of hospital stay, the progression to ventilation, or survival were unaffected, or there was no benefit as far as this meta-analysis or systematic review is concerned. So based on this meta-analysis and based on the data from the Solidarity study, the WHO published on the BMJ website jointly something called a living guideline. And this can be accessed on either the WHO website or the BMJ website. Basically, they say that they have WHO strongly recommend for the use of systemic corticosteroids, namely dexamethasone, in patients with severe and critical COVID-19. They have a conditional recommendation against the use of remdesivir in hospitalized patients with COVID-19, regardless of disease severity. They have a conditional recommendation against the use of corticosteroids in patients who do not require oxygen, the so-called non-severe COVID-19. So as we saw from the study, there was no benefit, no survival benefit if you give dexamethasone to patients who are not requiring oxygen. In fact, the standard of care was better than adding dexamethasone to those patients who did not require oxygen. So those were the WHO recommendations on this WHO BMJ living guideline. And this is a picture from that website. And you can see that they divide the severity of disease to non-severe, severe, and critical, with no recommendation whatsoever in any of the three groups for remdesivir, but they strongly recommend dexamethasone for the severe and the critical groups, but not in the mild, non-severe group who do not require oxygen. So this is basically a summary of the WHO recommendation, but it is, as the name describes, it's a living guideline. So if you go on this website and click on remdesivir, it will give you the latest information. And if you click on the steroids, it will give you the latest recommendation. So it's a live or living guideline. The BC, the province of BC has created a COVID-19 therapeutics committee that meets regularly, almost weekly on a Friday. Today I had to take my leave because the meeting is happening right now. I had to excuse myself to come here. So essentially, this guideline is available on Northern Health physician website as well, and is constantly updated. Currently, the remdesivir section almost agrees with what the WHO recommendations I just presented, in that it was agreed that remdesivir should be used within studies or within controlled trials. But Health Canada went ahead and purchased a shipment of remdesivir and then distributed it to the provinces and said people can use it. But this has to be judged carefully, because remdesivir is not without its side effects. It cannot be used in people with GFR less than 30. It may cause acute kidney injury. It may cause nausea, vomiting, phlebitis, hypokalemia, and many other side effects that we may not know about. So it has no survival benefit, no benefit as far as progression to ventilation. The only benefit that is documented so far is a 4-day reduction in the recovery time in patients who require low levels of oxygen therapy. And there's still more data to come out on remdesivir that we await. So we have to be very careful about using remdesivir, because it is not without its side effects, and it's not cheap. It's about $3,000 a course. Finally, I just have put this study to show that hydroxychloroquine not only failed to have an impact in the treatment of patients with COVID, it also failed miserably to prevent COVID-19 in those individuals who were exposed to it. So this was a study looking at contacts, some of them healthcare workers. 17% were actually healthcare workers, and the others were close contacts of patients with COVID. So it was a randomized study giving hydroxychloroquine for 2 weeks to those contacts, or vitamin C, either vitamin C or COVID for 2 weeks, and then to see who gets COVID. And this was a graph. There was really no difference. between whether you got vitamin C or you got hydroxychloroquine. No benefit in prevention of COVID in patients or individuals who were exposed to COVID-19. So hydroxychloroquine should be history in terms of treatment and prevention of COVID-19. The other drugs that are being studied are the anti-IL-6 group of drugs, convalescent plasma, IVIG, monoclonal antibodies, the drug that famously was linked with Mr. Trump, Regeneron. All these we don't really have enough data on, and they're being studied, and we await more studies to be published. At the moment, there is nothing to say that any of these drugs works, and they should not be used routinely, or because we just don't have the evidence for their use, and we await to see what the studies show. Vaccines are on the horizon, and there are four, or maybe for the Western world, there are three main candidates. The Pfizer messenger RNA vaccine is reported to be 95% effective. There were 44,000 study participants, 2 doses given 0 and 28 days. I just read today that the NHS hospitals have been notified to prepare for receiving the vaccine for their healthcare workers in the first week of December. So hopefully other countries and Canada will follow suit. Moderna vaccine is a US government funded vaccine, 94% effective, 30,000 study participants, again 2 doses. And those two vaccines require refrigeration. For Pfizer, it's -70. For Moderna, it's -20. The advantage of the Oxford AstraZeneca vaccine is that it doesn't require such degrees of refrigeration, cooling or refrigeration, and they can be kept in the at normal fridge temperatures, or 4 degrees. This was a different vaccine in its preparation. Those two were messenger RNA-based technology. This was a non-replicating viral vector. It's 70% effective. There were 12,000 studied, but the US cohort of this vaccine is still out. It's not published yet, so probably the total number will be a lot more than that. They were, it's also given in 2 doses, 0 and 28 days. This is a China based vaccine, and it was again 2 doses, but shorter interval between the doses, but we don't really know enough about it. It's an inactivated vaccine, and I believe it is being used in the Gulf already. So this is all what I have to say. In conclusion, COVID-19 is a global pandemic that's still raging, as we know, and you hear about it in every news bulletin. And it's causing significant morbidity and mortality. In Canada, over 90% of those who died are above the age of 70. So the elderly are particularly, nursing home patients are particularly vulnerable, and they should be among the first to be vaccinated. Management is still predominantly supportive, but we have solid evidence that dexamethasone improves survival in patients who require oxygen or require mechanical ventilation, but not in those who do not need oxygen. Remdesivir shortens recovery by 4 days, but has no benefit on survival or progression to ventilation. Vaccines, as I mentioned, are here, and it's a matter of weeks probably before they start get distributed. And let's hope that Canada can get some of those supplies and distribute them to the vulnerable populations. Prevention is still our best intervention, and Dr. Henry keeps reminding us about that, and we need to follow her advice and guidance. With that, I thank you for your attention. I'm happy to answer any questions.
Thanks, Abu. I had one question regarding our patients that have COPD or are already on oxygen for some reason, already have SATs that maybe are below 90. I mean, obviously they're in a compromised position already if they get COVID, but would you start those patients on dexamethasone immediately if they are already on oxygen, or what would our criteria be for doing that in that population?
That's a good question. Essentially, what is required is a drop in their baseline from their usual baseline. Because if you give them, I mean, you know, if they require steroids for an exacerbation of their COPD anyway, you can make that steroid, dexamethasone, 6 milligrams a day.
Thank you.
But if they don't need steroids, then yeah, you need a drop in their baseline oxygen level.
I have a question about the vaccines. Is there any sort of side effects that we know of? Is there a possibility of getting any sort of like GBS type of syndromes or anything like that?
Not that we know of. I mean, clearly those you know, vaccines or this data hasn't really been published, and it's all been press releases and so on. So we don't really know all the but from what we know, and from one people like Dr. Fauci, who probably seen the data, tell us that they are very safe, and there have been no major side effects that he talked about. But I haven't seen, obviously, this data, and I have to rely on others who tell us that they are safe. But until we actually see the studies published, we can't say for sure whether they were incidents or not.
Thank you.
Dr. Hamour, is there any evidence for melatonin in prevention?
Not that I'm aware of.
Alex here. You mentioned vitamin C as a placebo versus hydroxychloroquine. Is there any evidence that vitamin C, especially in the IV form, is useful in decreasing symptoms and severity of disease?
No, and I think there were some early studies looking at that, but they didn't really come up with anything substantive.
Thank you.
Jumping off from Nav's question, I suppose, how would you counsel patients who are having a little bit of hesitancy around a potential COVID vaccine if they had more questions about how the process got sped up but is still safe?
Well, that will depend on our own conviction first that they are safe. You know, I mean, we can't really counsel people about something that we don't know for sure. So we need to see the data. We need to see the evidence that these vaccines are safe. From what we hear, they are. You know, I mean, there's been no major flags raised, whether in the UK for the or Germany or the US about their safety so far. But in general, we have to rely on the risk-benefit analysis. You know, COVID is a lethal disease, especially in those who are above a certain age. If there is a vaccine that has efficacy rates of 95%, that is those numbers are like measles vaccine, or you know, this is those are highly effective vaccines, and you know, for a very serious and lethal disease. So you know, it's a risk-benefit analysis. If you're going to get a sore arm, you know, for a vaccine that is going to save your life, I know exactly what I would choose. You know, I would have a sore arm any day. But if you know, if a vaccine is causing major side effects, and obviously that is not, people are maybe reluctant to have it. But so far, from what we know, from the companies that are producing these vaccines and from the people who are privy to the data, like in you know, NIH and these institutions, they have been very positive about it, and I think we can you know, if we get the vaccine before we get the data, we can use that. But hopefully we'll get the data before we get the vaccines.
Thank you.
Any other questions?
Abu, can I ask just a quick question?
Sure.
So I just asked about how much remdesivir costs. So if it's really doesn't have any, I mean, I assume the only patients that would get this are inpatients. I doubt you give this on an outpatient basis. Is that correct, first of all?
Well, that is precisely what the WHO is recommending against. It's recommending against giving it to inpatients because the evidence for survival is not there. The evidence for preventing progression to ventilation is not there. So the only group, the only advantage for this drug so far that is 4 days shorter duration of illness. So they are, I think they are talking about producing an oral vaccine. An oral remdesivir. But when that comes, we don't know. Whether that's going to be studied in trials, we don't know. So there are a lot of question marks about remdesivir efficacy. And if you're using a drug that costs $3,000 to shorten the illness duration by 4 days, you have to do your cost-benefit analysis. At the moment, we don't have to do that because the drug has already been purchased by Health Canada and is being given to the provinces. But as soon as that supply runs out, each province is going to have to make its own cost-benefit analysis and see whether they want to license this drug for the benefit of 4 days shorter duration of illness.
That's easily $30,000. I think you give it for 7 or 10 days. I stand to be corrected. It's
$3,000 a course.
A course. Yeah. Okay. Yeah, I know that it's been used in our hospital on a couple of patients, or at least one I'm aware of. So anyway, I have my doubts about that drug, but.
Yeah, well, your doubts are shared by the WHO.
I'll go work for the WHO.
Yeah, here it is, against remdesivir in hospitalized patients.
I think we had just one more question.
Sure.
And it said, after the 10-day course of dexamethasone from the recovery trial, did they use a taper afterwards? And is it recommended we taper the dexamethasone?
No, no taper. And in fact, you don't have to give it for 10 days. If patients are better and well enough to be discharged, before the 10 days, the dexamethasone can be stopped on discharge. So 5 days would be sufficient if the patient already recovered and is ready to go home. You can stop after 5 days or 7 days. So they don't need to finish the 10-day course. So definitely no taper.
Hi, this is Yana. I have a question.
Sure.
Abu, if you decide to do titers and you have any sort of antibody titer positivity, do you still need the vaccine?
That is a good question, Yana, and I don't know the answer to that because we don't know what having antibodies mean because we know that there have been reinfections in people who have had COVID, had it again. So what does natural antibodies presence of natural antibodies mean? Does it mean immunity? For how long? We don't really know the answer to that. My own, view, which is not really based on any science that I can find, is that even if you have an antibody, you should get the vaccine.
Thanks, Abu.
Yep.
I have one question, Abu.
Sure.
Satish. I think it might be same, but Yana asked. So this test that recently came out, right? Life Labs offering some kind of, antibody titers. So this patient of mine, 49-year-old, who had COVID in March this year, and she has history of sarcoid, and she has tested, positive on 2 occasions. She continues to suffer from, dyspnea and other stuff, like chest pains and stuff. And she tested positive, like the IgA, GNM.
Yeah.
And she was, that just came out, a couple of days ago. I was going to call either you or somebody from ID team. And I told her, I said, I don't really know what that means. Like, what does that mean?
Well, basically, it means that somebody's had COVID at some point in the past.
Yes.
That is all what it means. It doesn't tell us whether, how long ago it was. It doesn't tell us whether that. It's only useful, really. I mean, I only requested antibody tests only once in the last 9 months or so. And that's when we had a patient who had a neurological syndrome, like a Miller-Fisher syndrome, who could have had an illness compatible with COVID back in January. So we, and it wasn't diagnosed with COVID at the time. So we just wanted to see whether this Miller-Fisher-like syndrome, which has been reported in the literature as a complication, as a long-term complication of COVID, whether this patient illness was due to an undiagnosed COVID infection in January or not. And I still haven't got the result of that test yet, so I don't know. But there is really no other indication to do the antibody test because it is retrospective. It doesn't tell you what's happening now. There are far better tests. The nucleic acid testing is the standard of care, whether that's a nasopharyngeal swab or whether it is a sputum or even just an oral swab, because there are tests that are available now that even use saliva. So any of these would be better than an antibody test. Or what you can say, like with any other antibody, if you do an antibody for anything, it just basically tells you that somebody has had this infection at some point in the past.
Okay, thank you, Abu.
So again, building up on the previous questions, the virus, so the antibodies don't tell us whether we are protected from the virus and the second infections. Now, the vaccines that were developed so rapidly, how exactly was this 95% effectivity tested? In other words, they were vaccinated, they were exposed to the virus, and they did not get an infection. So once we get a vaccine, presumably we get some antibodies towards whatever the bug is. And how long are we protected for? Like, do we have to get a vaccine, like there are 2 doses are needed, but what about after the first month or 2 months or 3 months? Is the effect going to be the same as with, like you just explained, testing for antibodies doesn't really give us much information. Do we even know?
We don't at the moment. These are all very good questions, Alex. And the way they did these vaccine studies is that basically they vaccinated some people and had controls, and they monitored the controls and the and those who were vaccinated, and so who got COVID, and compared the two groups over a period of time. But we don't really know the details. As I mentioned earlier, we don't really know the details of all these vaccine studies because they haven't been published. and we only got press releases and sound bites here and there. So we're still a little in the dark about the details of these vaccine studies. How long the vaccines will remain effective, again, that is a question that time will only tell. Nobody can predict that. But we know that from case reports that there were people who were infected with COVID more than once. And that's not surprising. I mean, we know from our knowledge of other viruses that happens. You can get the flu more than once because these viruses can mutate and may change their surface structures and so on and evade the immune system. How good these vaccines against them are going to be, only time will tell. But there are lots of unanswered questions. And, I wish if I could answer your questions, but at the moment we just don't have enough information.